Okay. Thank you once again. Okay, so I'll be presenting on a a very important topic in cardiology. A little bit complex. I mean, due to the pharmacological twist, but I'll try to keep it as simple as I can, so I don't end up confusing myself and the others. Okay, so I'll just quickly go through the pharmacology of inotropes and vasopressors. So, but before I move ahead, please next slide. Before I move ahead, I just wanted to quickly take us through. I mean, most of these vasopressors and inotropes are used in the treatment of shock. So I just wanted to do a brief revision, which I'm sure majority of us are aware or familiar with. So you have four types of shock. You could have so the distributive shock. So distributive shock is mostly the shock you see in people who have sepsis. So you have when you have basically peripheral vasodilatation, and then you have a lot of the fluid seeping into the third space. So it can be very challenging for doctors to treat. Then you have the hypovolemic shock, which is usually loss of effective circulatory volume. Commonly, you find it in those with trauma or those who undergo extreme fluid and electrolyte loss, so like maybe those with extreme vomiting, those with cholera, etc. And then we have cardiogenic shock, which most of us are probably very familiar with, and you tend to see a lot of cases in cardiology presenting with such. So that's just essentially a pump failure where the main center pump, which is the heart, for due to one etiology or not, or the other finds it difficult to pump. So the circulation is fine, but the main pump is defective. And then we have obstructive shock, which is essentially where you have a reduction in venous return through different etiologies, commonly those that tend to restrict cardiac feeling. So you could have your tamponade, tension pneumothorax, and then even pulmonary embolism, especially the severe form of pulmonary embolism. So the whole idea is just the pathophysiology or the etiology of the shock sometimes affects the approach which you use in the treatment of the shock, and then it also informs your choice of pharmacological agent as well. Please, next slide. On to the next slide. Okay, so another quick recap. So essentially, our autonomic nervous system is divided into a parasympathetic and sympathetic nervous system. So you have your ganglionic receptors, and then you have your postganglionic. So for the preganglionic, they're identical in the sense that the neurotransmitters are the same, which is acetylcholine. But the difference comes in the postganglionic receptors. So where you have muscarinic for the parasympathetic and the non-adrenergic. I'm bringing up this slide because the postganglionic receptor of the sympathetic nervous system is the area of interest, which most pharmacological inotropes or vasopressors tend to act. Okay, next slide. So just this is another quick revision. So we have different receptors, sympathetic receptor types. So we have the alpha 1, alpha 2, and beta 1, beta 2. We have the vasopressor 1, 2, and then the dopaminergic receptors. So the alpha 1 are the ones, I mean, alpha 2 is not listed here because it's not really the area of interest. I mean, it's commonly found more in CNS. A little, to some extent, is found in the vasculature as well, and then in the pancreas. But we'll just focus more on the others because those are the ones that most of the pharmacological agents act through. So alpha one someone says she can't hear anything. Can others hear me? Or it's
Yes,
we can hear you.
We can hear you.
Okay. Thank you. So so alpha one is primarily found in the vascular smooth muscle. So and usually when they are stimulated, they tend to bring about vasoconstriction, and that also contributes to your afterload and thereby affecting your blood pressure. Beta one are primarily found in the heart and to some extent the intestinal muscle. So this is one of the major receptors, sympathetic receptors that is also targeted by most of our pharmacological agents, and they directly increase inotropy in terms of your cardiac contractility. So it could affect either both the strength of contraction plus or minus the chronology as well. So the rate at which the heart beats. So contraction, strength, and then rate. So beta 2 is usually found in also the vasculature as well. It tends to have an antagonistic effect for alpha 1 in the sense that when it is stimulated, it tends to cause vasodilatation. It's also found in the uterine smooth muscle, but primarily, I think what's also in importance in our cases, it's also found in the bronchial, the smooth muscles of the bronchioles. So, I mean, there could be an overlap with regards to those who have corresponding bronchospasm or asthma. So that, to some extent, may also influence your choices of pharmacological agents. Next. Okay. So then we have our dopamine receptors. Dopamine receptors are found mostly in the GI tract and mesenteric vessels, as well as our the renal vasculature as well. And stimulation also increases blood flow to the kidneys, as well as improves natriuresis and urine output. B1 and B2 receptors are found. So that's B1AB. 1A is found in the vascular smooth muscle, B in the pituitary gland, and B2 is found in the renal collecting duct. So basically, stimulations of B1 tends to cause vasoconstriction, and then B2 tends to enhance salt and water retention by increasing your aquaporin channels. This next slide. Okay, so basically, vasopressors and inotropes, in just very simple terms, vasopressors just essentially mean medications that cause what do you call it? That cause constriction of the vessel, and then the inotropes essentially increase contractility in just very simple terms. So they are medications that are used in the setting of shock or extremely low BP, and they've been a hallmark in terms of critical care management with regards to management of shock, because we know that most of the time shock, if not properly managed, will lead to multi-organ dysfunction and death. But the issue now becomes that in as much as they may be helpful, they also can cause harm if probably not well used or probably wrongly prescribed. So there are medications that we should use with care and make sure that the benefits outweigh the risk they possess. So, and the most important thing I would like to stress on is that majority of all vasopressors and inotropes contribute to the journey, they are not the destination. So they serve as a kind of bridge to the ultimate therapy of treating the underlying cause of your shock. So they just help you buy time whilst you try to solve the underlying problem. Okay. And then they work, like I said, through the autonomic nervous system, like I mentioned earlier. Please, the next slide. So I also just wanted to bring bear that adrenergic receptors can be affected in terms of sensitization and downregulation, depending on the particular condition. So conditions like hypoxia, acidosis or acidemia, chronic heart failure can affect the effect of the pharmacological agents you're prescribing. So that you should also bear that in mind in your approach to taking decisions with regards to critical care. And inotropic and vasopressor agents have increasingly become a therapeutic cornerstone for the management of several cardiovascular syndromes. This next slide. So I just wanted us to also know that these substances can either be excitatory or inhibitory, and they can act either on the heart itself or the vasculature or both, depending on the pharmacokinetics of the particular um, um, molecule. And they tend to play a role, like I said earlier, in short to medium term clinical recovery. So they don't, unless it's a terminal case, they don't tend to play any long term role, because they can, on their own, when used over a period of time, can increase your risk of developing complications and even mortality as a whole. So as much as possible, if you can avoid using them, you don't use them. Okay, next slide. So most vasopressors have multiple actions on the heart and vasculature, like I mentioned earlier. They also come, like I said, they are not harmless medications, so they tend to come with their own risk. So you always have to balance the scales and determine and make sure that somebody really needs it before they are put on it. Okay, next slide. So I'll just quickly go through a classification. So if you look on the left, so there are, I came across two literature. Commonly, the ones on the left are the common classifications you see in most literature. So they are divided into catecholamines, phosphodiesterase inhibitors, vasopressin, or ADH-like molecules, calcium sensitizing agents, and granulate cyclase and nitric oxide synthase inhibitors. But on the other side, sometimes you see or come across classifications like inoconstrictors, inodilators, So basically, they just use the pharmacology to try to describe the class of the medication. So inoconstriction just basically means inotropic and constrictive. So they both have inotropic and constrictive effect. So they both affect the heart and then the vasculature. Then you have your vasoconstrictors that just strictly act only on the vasculature. They don't have any effect on the heart itself. You have your inodilators. So inodilators are those that cause both increased inotropy, but also cause vasodilatation in the vasculature. And then you have vasodilators, which just cause peripheral vasodilatation. But that wouldn't go into vasodilators because that's outside the scope of what we are talking about. So, I mean, just basically, sometimes they use them interchangeably, but I would tend to go with the classifications on the left for simplicity. Next slide. So this is just basically, I mean, please ignore the slide's a little busy, but I think it's just for those who, if you want to read on it. I choose to put the literature on the side. It's just basically the physiology behind how the catecholamines work. So so they essentially are beta agonists and they work on the beta receptor on the cell membrane. So they activate glycoprotein, which tends to what's the word? So it activates adenyl cyclase, which increases cyclic AMP. So if you go to the left-hand side, that's the effect it has on beta 1 receptors. So you have calcium channel activation, then you have a surge in the calcium in the cytosolic calcium, and then leads to actin myosin troponin interaction. So it can affect it in two ways. So you have either positive conotropy or positive inotropy. So you tend to have them occurring together, but not in all cases, because some medications can affect either or both. Then when it comes to on the right-hand side, the beta 2 agonist. So it's basically the same pathway, but slightly different. So it goes through the increased cyclic AMP, and then it increases phosphorylated phospholamban, and then it causes augmented uptake of calcium by the sarcoplasmic reticulum, and then leads to vasodilatation. So there's just slight variation in how it affects the beta 1 receptor on the left and then the beta 2 receptor on the right. Okay, next slide. So we'll just go through the tactical imines one after the other. So I'll first take dopamine. It's an endogenous central neurotransmitter. I mean, it's quite commonly used in the part of the sub-region. I mean, we use it a lot in Accra where I practice. Probably it's more affordable and it's cheaper. It's not the most popular category in the West. I mean, there are a lot of issues with dopamine. Dopamine, it's a drug that can be very erratic in terms of its predictability. I mean, it can affect your dopamine receptors, it can affect your beta receptors, and it can affect your alpha receptors, but it's dose dependent. So the lower the doses, it tends to affect your dopamine receptors. So, and when it is in low doses, it tends to cause renal perfusion as well as natriuresis and increased urine output. So this can, probably in a critical care setting, even be a bit confusing, because in a critical care setting, anyone passing urine, you presume is doing well because the kidney is being perfused. But here it is, probably the person is going downhill, but your dopamine is, giving you a false sense of, improvement with regards to homeostasis. So you have to be very careful. Someone on dopamine who is passing adequate urine may not necessarily be improving, but it's just due to the effect of dopamine on the D1 receptors, D1 and D2 receptors in the kidney. So please, next slide. So as you tend to increase the dose, then it tends to affect the beta receptors. So intermediate dose beta receptors, smaller dose dopamine receptors, and the far higher doses tend to affect your alpha 1 adrenergic receptor. So it can cause a lot of vasoconstriction. In low doses, it's very mild vasodilatation, but as you increase the dose, it tends to have more predominant vasoconstriction. Next slide. So, the side effects of dopamine, it can increase your risk of arrhythmias, and then in very high doses as well, it can also cause peripheral vasoconstriction and can increase your risk of having tissue necrosis, especially when it spills over in the surrounding or local tissue. That's why one of the reasons you are advised to use a central line, except in emergency situations where you don't have the luxury of passing a central line. But you always advise, a central line, you always advise to avoid using it peripherally because it can cause tissue necrosis. So we'll go to dobutamine. So dobutamine, is one of the probably first choice or drug of choice for, and tends to cut across with regards to a lot of indications when treating shock. So dobutamine is a synthetic catecholamine, and it tends to have a strong affinity more for beta 1 and beta 2 receptors with a mild um, um, involvement with your alpha 1 receptors. So it has more beta 1 stimulatory effect, and it's a very potent inotrope. It tends to be the drug of choice in majority of the shocks, cardiogenic, even it's also very good drug to use in septic shock as well. So it tends to have a net mild vasodilatation because of the beta 2 stimulation. But in higher doses, you tend to have a more predominant alpha 1 effect, causing vasoconstriction. Please, next slide. So when you go beyond doses of 15 micrograms per kilogram, then you tend to see a lot of peripheral resistance because of the alpha 1 mediated vasoconstriction. So basically, another downside besides the risk of arrhythmias, what dobutamine is quite notorious for is it increases your risk, your myocardial workload. So it increases your risk of developing ischemia. So because of the increased inotropic effect, there's a lot of oxygen demand or oxygen hunger. So it tends to worsen, and it's not necessarily dose dependent, even in the smallest of doses. So that's one of the major downsides of dobutamine. So you have to be very careful, especially in settings where people are prone to ischemia. You have to tread with caution because you may end up worsening the patient's condition when they're ischemia. So, but because of the effect it has, the exercise mimicking effect, that's the basis on which it's used as a pharmacological stress agent in diagnostic perfusion imaging. But it tends to can limit its use when you may cause ischemia and worsen the patient's condition. And another thing too is that the tolerance of dobutamine tends to the tolerance, basically the person tends to develop tachyphylaxis as time goes on. So they tend to become more resistant because there's a down regulation of your beta receptors as time goes on. So eventually, when it's used for an extended period, it can become less effective. Okay, next slide. Okay, so I think I've basically talked about this. Just highlights the risk of developing an ischemia and infarction. So just use it with caution when your patient is at increased risk of ischemia. Okay. So I'll go to norepinephrine. So it's a major endogenous neurotransmitter. It's a very potent alpha 1 vasoconstrictor. It has a modest beta agonist activity. So that's the reverse with epinephrine. So epinephrine tends to have a strong beta agonist activity and a modest alpha 1 agonist activity, and norepinephrine is the reverse. But you also have to bear in mind that in very high doses, epinephrine is a very potent vasoconstrictor on its own. So they work so I mean, these are one of your very reliable pharmacological agents that it's very useful in several types of etiologies of shock. I mean, increases systolic and diastolic pressure, and it has a minimal impact on the net cardiac output. It doesn't have as much effect on gonotropy like epinephrine. So it tends to be a bit more appropriate to use than epinephrine when it's a condition where the heart rate is an issue. So you don't want to introduce a pharmacological agent that worsens maybe the person's tachycardia. So it's probably preferred in that case when it comes to choosing between it and epinephrine. And it's also very good in septic shock as well. But in general, it tends to cut across several degrees of shock. So, next slide. Another important thing is that despite its inotropic effects, it tends to have an increment in cerebral and coronary artery blood flow. So one coronary blood flow is increased because of increased diastolic blood pressure, and we know that the coronaries are perfused in diastole. That's one. And then two, it tends to have an indirect stimulation of local cardiomyocytes where they release local vasodilators. So when you use norepinephrine or epinephrine, coronary blood flow is actually quite good. It doesn't tend to impair it in any way. But like most catecholamines or most inotropes or vasopressors, prolonged infusions can cause problems. I mean, it can cause apoptosis. It can, it can also cause even, what do you call it? Peripheral vasoconstriction. So you could have peripheral ischemia of your organs as well due to a persistent, like a reduced blood flow to the periphery when you use very high doses, especially. Next slide. So epinephrine is similar to norepinephrine. I think the only twist is it tends to favor more the beta agonist effect than the alpha agonist effect. So it tends to be more inotropic and tends to be less vasoconstrictive, but that is nullified when the doses are very high. So it's also another go-to drug, but and it tends to be very effective in terms of your inotropy and sustaining your blood pressure. But it's also another drug that is not advised to be used long term because it can increase your risk of arrhythmia, sudden cardiac death, as well as peripheral necrosis as well. Next slide. So similar to norepinephrine, coronary blood flow is also fine. It may also cause arterial pulmonary artery. It will also cause pulmonary artery constriction. So long-term use can also be associated with pulmonary hypertension, and then you could also have, when it's sustained, right ventricular dysfunction as well. So, and it has a direct cardiotoxic effect when it's used for a long period of time. But these two drugs, epinephrine and norepinephrine, tend to be very good when cardiac arrest, and those who are asthmatic, those who have bronchospasms, and then those who have what do you call it? Shock from those who have probably have
anaphylaxis.
What do you call it? Yeah, anaphylaxis, exactly. That's what I'm trying to, yes, because it also stabilizes the mast cells as well and reduces the histamine release. So it's a good drug in that sense. Okay, so next slide. Okay, so I'll go to isoproterenol. So this one is very similar to noradrenaline, but it tends to be it's more beta specific, and tends to have a very low affinity for alpha adrenergic effects. So it's a very good drug with regards to phonotropic and inotropic properties. So it's just basically a drug that will be good for those who have very low BPs and those who are bradyarrhythmic. It's been shown to be very useful in treatment of such patients. So I think essentially it's just a good substitute for your noradrenaline or and adrenaline, especially when the focus is just primarily on inotropic outcomes or effects. Okay, next slide. Okay, so I'll go to metaraminol tartrates or metaraminol. So they are potent synthetic sympathometics, and they act on both alpha 1 and beta 1 receptors, but they tend to have no effect on beta 2 receptors. So they can cause peripheral vessel constriction, and they have a positive inotropic effect. So they tend to result in increased systemic blood flow. So it's one of the downsides of the medication is that it may induce a reflex bradycardia because of the sudden, it can cause sudden BP rises. So it can induce reflex bradycardia. Next slide. So this is just basically a schematic. So this is catechol-imine, but this is how they work on the vasculature, so the alpha agonist. So you stimulate your G protein, and then your second messenger is phospholipase C, which acts through PIP2 and DAG. So you have PIP2 causes an increase in IP3, and then increased cytosolic calcium, and activates protein kinase C. So you tend to have a calmodulin dependent protein kinase vasoconstriction, essentially. So this is just by the way. So I'll go to the catechol-imines that are more alpha 1 bias. So phenylephrine. So this is it's a very potent synthetic alpha adrenergic stimulator. It has little or no effect on your beta adrenergic receptor. So this is when you are trying to target hypotension that is not directly originating from the heart itself or the cardiac myocyte. So you have conditions, it raises your mean arterial pressure. So conditions that it is indicated in those who have severe hypotension in the setting of aortic stenosis, or those who have taken your phosphodiesterase inhibitors, so sildenafil and nitrates combination, or those who have hukum with decreased outflow tract agent. So these are the ones that you just want to concentrate on vasoconstriction and raising the BPs, because you don't want to, in most of these conditions, you don't want to stimulate beta 1 receptors, because you may worsen the outcomes when you do that. Okay, next slide. So basically, it has no direct effect on heart rates, but it tends to cause a rapid rise in your mean arterial pressure, but it may induce a reflex bradycardia. That's one of the potential side effects. Okay, next slide. So we move to the next group. These are the phosphodiesterase inhibitors. So basically, they tend to work. It's essentially the same pathway, but if you look at it, they go through the beta receptor, the glycoproteins, the adenyl cyclase, but the phosphodiesterase are enzymes that break down your cyclic AMP. And this your cyclic AMP are the ones that contribute to myocardial cell contraction. So if phosphodiesterase inhibitors inhibit the breakdown of cyclic AMP such that there's an increased build in your cyclic AMP, so you can indirectly or directly affect contractility. Okay, so for the phosphodiesterase inhibitors, essentially they just increase the level of cyclic AMP. So they act through two mechanisms. One, they increase inotropy, and then they cause vasodilatation as well. So thereby reducing your preload and afterload as well as your systemic vascular resistance. Another thing too that is very very advantageous when it comes to these medications is they don't increase they increase diastolic relaxation, so which is gives it an edge over most of the catechol ailments, because those ones tend to increase your oxygen demand, especially in diastole. The energy required even in they tend to inhibit diastolic relaxation, but this doesn't have, it tends to rather improve it. So you don't tend to have the same increase myocardial oxygen demand like in the previous in the catechol image. Next slide. So I think the main phosphodiesterase inhibitor that is popularly used mostly in the West is milrinone, and it tends to be used a lot in heart failure, and it can also be used in septic shock as well. It tends to have a slight advantage over dobutamine. I mean, studies have shown that they are non-inferior, they're equally as potent, so one is not better than the other. But dobutamine, when it's used over a prolonged period of time, it tends to become less effective, and because of the down regulations of the adrenergic receptors. So that's probably one edge it has over dobutamine. Next slide. So I think I've said this. It produces slight enhancement of AV node conduction as well. Amrinone is used less often because of increased incidences of dose-related thrombocytopenia. Next slide. So the next group will be vasopressin. So vasopressin are essentially analogs of ADH, and they are found in the posterior pituitary gland, and they are released in cases where you have increased plasma osmolarity or hypotension, and they tend to a lesser degree be released when there's in response to elevated cardiac wall stress by the heart and then the adrenal gland as well. They work by two mechanisms. So they affect both the V1 and then the V2 receptors. So the V1 receptors are found in the vascular smooth muscle, so they cause vasoconstriction, and then the V2 receptors are found in the renal collecting tubule duct system. So they tend to increase your aquaporin channel activation. So they cause a lot of salt and water retention. So basically, one, vasoconstriction, and then two, salt and water retention. Next slide. It's been shown to also be very useful in those who have septic shock with diabetic insipidus. It's also been found to, I mean, it's also a worthy substitute to some of the catecholamines as well. It can be used in septic shock as well. It tends to, in general, cause um, the elevation of your blood pressures by virtue of causing vasoconstriction and salt and water absorption. Next slide. So it's also been shown it's been shown to potentiate the effects of norepinephrine when they are used together. So it further augments or has a synergistic working relationship with norepinephrine. And then it also causes, it can cause some degree of vasodilatation as well, due to the inhibition of ATP activated potassium channels and attenuation of nitric oxide production, as well as reversal of adrenergic receptor downregulation. So this is also a very good drug to use when the patient is very hypoxic and acidotic, and it tends to cut across. It tends to be useful regardless of the pathophysiology or the etiology of the shock. So it's also a very useful, although an expensive drug. Next slide. So the next group are calcium sensitizing agents. They are one of the recently developed inotropic agents, and I think levosimendan tends to be the most well-known drug. So it has two mechanisms of action. So one, increases sensitivity of contractile proteins to the surrounding calcium. So it doesn't necessarily increase the amount of calcium in this cytosolic calcium, because that also in excess can also worsen your diastolic function as well. So it increases its sensitivity such that it doesn't affect diastolic relaxation, but it also affects contractility, and it also causes opening of ATP-dependent potassium channels as well. So those are the two main mechanisms of action of the calcium sensitizing agent. It's also quite a popular medication, especially used in heart failure as well. So it's one of the drugs that is popularly used in management of patients who have heart failure and cardiogenic shock. Next slide. So I think I've said this. So it's an increasingly popular, becoming an increasingly popular pharmacological agent in the management of hypertension in acute and chronic heart failure. Okay, next slide. So, and then the last group will be guanylate and nitric oxide synthase. So these are one of the new drugs. I think the main agent is methylene blue. We mostly all know methylene blue as one of the treatments for methemoglobinemia, but it generated a lot of interest. It's a drug that is a go-to drug, especially in the setting of when you have a lot of peripheral vasodilatation, especially like in septic shock. Tends to be one of the add-ons when you are a little stuck and everything doesn't seem to be working. So in the setting of cardiogenic shock related to CIS or systemic inflammatory reconstitution syndrome, its therapeutic effects are basically it causes inhibition of nitric oxide and mediated cyclic GMP production, resulting in increased muscle vasoconstriction. But you have to use it. You have to be very careful with patients who are being treated with SSRIs, as it may precipitate serotonin syndrome, and as well as patients who have G6PD deficiency as well, because they are at risk of developing hemolytic anemia. Next slide.
Okay, so I think this just round up in the next 10 minutes.
Okay. So basically, this is just a summary of, I think, a schematic of all the drugs. I just basically tried to summarize it to look at it. So you can look at this later. It's just basically the same schematics and shows where different pharmacological agents act. I think that's basically it. And then the net effect. So it's just all what I've said. It's all summarized in this one. So I think so. The first one is the cardiac tissue, and then the second one is on the vascular smooth muscle. So I think we can all, when I put up the slide, we can all look at it. Just a summary of all I've said so far. So come to the next slide. So this is also another summary of basically the indications of all the drugs broken down to their different groups, your catechol amines. So and then which receptors they affect. And then the side effect profile, essentially. So this is also another summary I've put in. I mean, makes it easier, at least just to summarize everything. So this is also a continuation. So your phosphodiesterase inhibitor, calcium sensitizer, and vasopressin and methylene blue. So this is just a summary of all I have said. Next slide. This basically just shows, I think, the effects of the medications on the cardiac physiology in terms of vasoconstriction. The one on the left, the inotropic effect or the vasodilatory effect. So it just gives you an idea of the medication. So this medication, the phenylephrine and vasopressin tend to cause more vasoconstriction. And then when you go towards the right, the norepinephrines, dopamines, epinephrine, so they basically tend to affect inotropy. And then your dopamine and milrinone. So those ones affect inotropy, but don't tend to affect your blood pressures a lot. Then on the right is essentially the same thing. I'm just repeating myself. Okay, next slide. Next slide. So I think I came across some trials. So just basically, I mean, trials trying to compare a lot of the inotropes and vasopressors to see whether one is superior to the other. But I think in general, besides, I think the only trial, I think this SOAP2 trial, where they found out that with dopamine and norepinephrine being used in septic shock, they found that there were increased arrhythmic events with dopamine, and then there was an increased 28-day mortality, but it's in a particular subset of people. So it's not really been clear cut. So there was room for confounders and all. But I think just in summary, what I'm just trying to say is that majority of these drugs have not really been tested in terms of landmark controlled trials, ROCTs. So they've not really been clear establishments of the superiority of one drug to the other. So it tends to be a lot more dependent on expert opinions, what is available, understanding the etiology or pathophysiology of the underlying shock, and then your approach, and then knowing the adverse effects as well, and then factoring that in. But these are just slides you can look at in your spare time. But in general, they've not been shown to be, besides dopamine, which the West is frowning on of late, but most of them tend to be very user dependent, if I would say so. Next slide. So I think these are just putting a lot of trials here. So you can just look at Triumph, Survive. They tend to not have any long-term mortality benefits over the others. So more investigations need to be done to have more conclusive evidence. Next slide. So I'll summarize by saying that Inotropes and vasopressors play an essential role in supportive care in a number of important cardiovascular disease processes. So the key thing we have to know that it's a journey, not a destination. It's bridging a gap. So the main thing should be to focus on the underlying etiology, whilst your inotropes and vasopressors buy you time. And as much as possible, try to avoid them if you don't need them. And to make sure the benefits outweigh the risk, because they can be harmful, especially when used in high doses and over a prolonged period of time. So as much as possible, try to wean the patient off the medications as soon as you can. I mean, it can be challenging in some cases, but as soon as you can, try to wean them off. And they are now advocating for trying to use the lowest possible doses of the medications, and if preferable in combination, because they found out that higher doses tend to be associated with morbidity and mortality, and then worsen side effects. So they always advocate for you to tend to, if you can combine them in smaller doses to give you the desired effects, that is preferred. Next slide. So no inotropic agents have been shown to have superiority over any others in good quality trials. Large RCTs focusing on clinical outcomes are needed to better assess the clinical efficacy of these agents. So the use is based on cost, availability, your interpretation of physiology, and personal and institutional preference. So I think I'm done. Thank you very much. So I'll pause here for contributions.
Yes. Wow. Thank you so much, Dr. Okechukwu, for a very comprehensive synopsis of the inotropes and vasopressor agent. Just one thing that I was curious about, you did not treat dobutamine like you treated the other catecholamines. And in our setting, people tend to use it a bit frequently, even more frequently than the phosphodiesterase inhibitors or calcium sensitizing agent. And there are some proponents who think dobutamine tend to have a better, tend to improve renal perfusion better than other, other vasopressor agents. I don't know what in terms of improving renal perfusion, what would be the best pick among the ones that you've discussed?
So to be honest with you, in terms of renal perfusion, the best pick is actually dopamine. Dopamine tends to be the most, with regards to, if you just strictly stand alone when you are looking at renal perfusion, dopamine tends to be the most potent because of the activity on the D1 and D2 receptors when it is in reduced doses. But you lose that as the doses, when you go to medium or higher doses, it doesn't tend to be as effective anymore. Dobutamine on its own too, it's very good in terms of its beta stimulation. That's one. Two, in small doses, it has mild vasodilatory effect. So it's good for renal perfusion when it's in smaller doses. But once you start approaching higher doses, more than 15 micrograms per kilo, then you lose that ability, because now it tends to be predominated by vasoconstriction. So in terms of smaller doses of dobutamine, there's some vasodilatation, peripheral vasodilatation, and you have renal perfusion, but it is not, it's not as efficient when compared to dopamine if you're looking strictly from a renal perfusion standpoint. But when you look at it in totality, in terms of the other benefits of dobutamine, I mean, it far outweighs that of dopamine. But the problem with dobutamine is it has issues of increasing myocardial oxygen demand. It also increases your risk of arrhythmias and sudden cardiac death. And then it becomes less effective when it's used for a prolonged period of time. I don't know if that has answered the question.
Yeah, thank you very much, Dr. Okechukwu. So the floor is open for colleagues to ask questions. If you want to ask a question, put up your hand or unmute and ask your question. As we wait for people to ask questions, there is a question on the chat box from Peter Mba. He says, thank you, excellent presentation. What's the drug of choice in cardiogenic shock secondary to STEMI?
So for cardiogenic shock, so so there's no one clear-cut drug of choice, but you could use so milrinone is very popular. It's a very good drug. I think it's probably in my opinion probably the best because it tends to come with far less baggage. So butamine you use, but you use with caution because you may end up worsening your ischemia, but it's not contraindicated. So milrinone, probably it's one. Then you could also use levosimendan. Those I think so. It's between levosimendan, dobutamine with caution, and then milrinone. But I think milrinone probably would be the one with the least baggage. So, but the problem is the availability in our set. So, yeah.
Yeah, I think I agree with you on that, Okechukwu. In the Western world, when they talk about shock in STEMI, mostly they go for either milrinone or levosimendan. But in our setting, you know, we don't have this medication. So most times here, when patients with myocardial infarction go into shock, dobutamine is what we want to. We tend to like, you know, there is the risk of increasing oxygen demand further, but then you have to weigh it against the benefit. When the patient is in shock, you have to give. So we give cautiously, yeah, because we don't have those other medications available. Right. But ideally, those levosimendan and milrinone are better than they will be your first choice to go to.
Hello,
Yes, please go ahead, Dr. Ojo.
Yeah, this is Dr. Ayodeji. Yeah.
Oh, Ayodeji, sorry.
Yeah. Well, I agree with you, just like you said. But we know that the mainstay is you want to reperfuse them as soon as possible. Cardiogenic shock will STEMI. The mainstay is reperfusion. You want to reperfuse them as soon as possible. Because those drugs might not really, but as soon as you're able to do the reperfusion, of course, they get better. Thank you.
Yeah, thank you very much. There's another question on the chat box from Peter Bai again. He said, I have known dopamine as 1 to 5 low, 5 to 15 moderate dose, and high 20 to 50. Kindly clarify. Dr. Okechukwu, can clarify the doses which are low.
This one it may be an issue of literature. I mean the dose I put up here is what I saw, but
okay.
Yeah, that's what I have seen. I've seen also 0 to 4, 4 to 10. So it tends to vary, but I think the main point we should factor in is that the dose affects the receptors that are being targeted. So when you have a low dose, you tend to affect cause diuresis and renal perfusion. When you get to the moderate dose, that's when you tend to see the beta adrenergic effects. And then when you get to the high doses, that is where you tend to see the alpha 1 vasoconstrictive effects. But majority of the times now, they are pushing for a combination as much as possible so that you don't have to get to high doses, because high doses tend to come with a lot of problems, side effects, issues with arrhythmia. So as much as possible, try to combine it in lower doses. So it's better you use 2 with lower doses than you use 1 with a very high dose. So as for the variations with the dosing, I think it's subject to literature. So you might not be wrong as well. So that's fine.
Okay, thank you very much. So a lot of thanks for you for the extensive and lucid presentation in the chat box. Are there any further questions from participants before we take comments from our chiefs? Okay, so I'll call on Chief Okopi. I think the Chief Adeyanju is also around. Yeah, please, if you can unmute and make your comments.
Thank you, Dr. Conte, for that excellent coordination. Thank you, Dr. Kichuku. Very brilliant presentation, in fact. I enjoyed every bit of it. Very clear. I don't have much to say, but let's see what Adeyanju, I think you're the one here. With respect to the exam, did you find anything here that you want to give us more light as we prepare? Okay, seems Adeyanju is not close to our phone, so can we, Alex, it will be.
Yes, sir.
With respect to the exams and your experience in practice, do you have anything you want to say about
Um, just to thank the presenter for the excellent presentation and to say that the major thing would be knowing the receptors and the various medications where they really work, because Prof tried to play around some of them, especially the ones that we don't use very commonly, Levamedan, Merinone, and then he kinds of twists it. So the receptors have to be clear on our mind, and then the messengers as well that they act on, whether primary or secondary, and what's the action of their the effect they have generally on the receptors. But during the last exam, there wasn't really much from this aspect, just like a few that came. But I think the emphasis would be on knowing the medications better, and then especially the receptors where they act on and their effect alongside with the whether primary or secondary messengers. Thank you.
Oh, thank you so much. Even though my network here was quite poor, I couldn't get part of what she was showing. Ayodeji, before we call on Igwe. Ayodeji, please, do you have more to say to this prestige of practice and with respect to the exam?
No, nothing to say. I already made my comment. Nothing else to say. I already made my comment, Chief.
I don't know if it's on my side. Network is quite terrible.
Yeah,
I'm
you're
not
breaking a
hearing.
little bit, but we are getting you now.
Dr. Conte, please, can you hear my voice?
Yes, we can hear you.
Hello, Dr. Conte. All right, so let's get Dr. John, Chief President, Dr. John Onyebueze Igwe. Sir, with respect to the exam practice, do you have questions to ask or contributions to make?
Dr. Kobe, just I think joined at the point you were actually speaking. I had some issues I was trying to battle with sort out. Well, essentially is what A2P also noted. There isn't any much new thing to add. Dr. Conte has already said the lecture was very clear. I will go by that. I will have to listen to the lecture myself too.
Okay. Hello, Chief Okopi. Okay. So just one more comment on the chat box. Dr. Ojo is saying, thank you for the presentation. I don't know if we can have the findings or conclusion of the studies added to the tables. Dr. Okechukwu, if you can do that before sharing the slides for the studies,
Okay.
adding the findings and conclusions.
Okay. Well, I should give more details, or because like I gave the tables had the names of the studies, so I don't know, or they still
Talking about
want
the conclusion. Let me just
okay.
see the slide and see. Okay, so Dr. Ojo, if you can see the slide, so it's just mortality. Yeah, the benefit on mortality. Okay.
I don't know. Is that enough for this? They still want more
Probably
detail.
he wants more. Dr. Ojo, if you can just say specifically what you need added to this slide. Dr. Ojo? Oh. Seems as if he has also gone off. Okay. So thank you once again, Dr. Okechukwu, for a very, very good presentation. We really, really appreciate you for handling this very important topic. I'll now, at this juncture, hand over to Florence to take us through the